Welcome back to Drunken Medicine, where we are drunk on medicine and passionate about whiskey. Hi, my name is Dr. May. I'm a naturopathic physician with 13 years of experience helping people treat complicated issues. Um, and currently, I'm in Montana setting up a new practice. So, Mike?
Hey, and I'm Michael Johnson. I'm an acupuncturist. I've been practicing for a lot of years now, almost 14 years. And I'm really excited about today just because this is, I treat all sorts of complicated conditions. And this is one that I've treated daily for 14 years almost. So it's going to be exciting. But before we get into all that, what you drinking?
And I am drinking a bourbon straight whiskey from the Montana Whiskey Company. So this is brand spanking new. I've never had this before. I thought, well,
Ooh.
since I'm in Montana now, it would be a good idea to get, a local whiskey. And I got to read the back end for this. It's hilarious. So it says, my grandparents headed west to Montana and homesteaded. Through time and exposure to this harsh yet beautiful country, they became rugged Montanans. They would say this land put Montana in their spirit. And at the bottom it says, the old pointer says, it's got a picture of a dog. It says, when the drinking starts, the shooting stops, or old hunting dogs end up with buckshot in their ass. Drink responsibly. It's like, that's awesome. Yeah. So, we're going to try it out and see how it is. It's really interesting. I've been here for 3 weeks now, and I've met some really interesting people, like people who are like fifth generation Montana, and like their great great grandparents actually came over like in a covered wagon,
Wow.
from like Tennessee and Kentucky and places like that, and they came here, and one of them actually makes their own whiskey, and but it's just the history here is really fascinating. A lot of homesteaders. People who've just been here for a long time, and just kind of salt of the earth people. I just love it. So anyway, I'm hoping this is a good whiskey. What are you drinking, Mike?
Oh, I'm excited. This is what I've been wanting to try for a while. This is a Powers Three Swallows Irish whiskey. So usually when I do Irish whiskey, I go with Redbreast because you can't really go wrong with Redbreast ever. But I'd heard good things about this one, and the story on this one's cool too. It's Three Swallows release proudly pays homage to the Powers family coachmen and their stable of horses. To keep warm in the harsh Irish winters, the three coachmen would each take a sip, yeah, I bet, from their hip flask, Three Swallows, thus the name.
Nice.
Yeah, and it's really nice. I mean, there's a lot of it's like candy and fruit on the nose.
Yeah.
And it's sweet and spicy, very, very sweet, but also got a little bit of spice and kind of oak on the back end, and it just lingers. It's really nice.
Yeah. Yeah. So this is only 80 proof. So it's really, really mild. Like it's easy to drink neat. As I'm drinking in my Avengers, coffee mug.
That's awesome.
Yeah, my whiskey glasses haven't made it up here just yet.
That's a proper glass. Come on.
Yeah, my boys would be proud.
Yeah, this one's 86.4 proof, but it's still really mild. You don't really have to add water. It's fine, neat.
Yeah, I really like this. It's a kind of mild, but it's got the sort of caramel and oaky kind of taste to it. No, it's really nice. Not too complex, but just kind of simple and good. Yeah.
Too bad it's illegal to send it over the mail. I'll have to come try it sometime.
Yeah, you'll just have to come up here and try it.
That's true. I need an excuse anyways.
I think it tastes better in Montana too. So
that's how it works with local stuff.
That's what I hear. I don't know.
Though it is kind of funny. I'm not going to bring up politics on this podcast, but I am drinking an Irish whiskey on Coronation Day. I just want to point that out. So
yeah, Coronation.
I make no other statement. No other statement at all.
You're not going to talk about the
I got nothing to say.
What is this? It's the biggest diamond, right, in the world. It's in the scepter or whatever that they're.
Yeah, they didn't bring it out this time. But my Irish friends are not celebrating today, and that's all I'll say. I got British friends too, so we're gonna leave it alone.
Yeah, all right.
But Irish whiskey is wonderful. I'll go with that.
Yeah, there you go. We can both get behind that one.
It's true. So I'm
All
excited
right.
about today, man. This is a big topic for both of us
Yeah. What are
because
we talking about?
we're talking about chronic pain, and we're going to be talking about pain in general today because I think that there's a lot of things that kind of cross over with various types of chronic pain. And then in future episodes, we can get into, more specific things. But today, I really want to just get into a broad overview with you because it's important. I mean, this is such an important topic that
Yeah.
so many people suffer with.
I should have. So if you guys have listened to a few of these episodes, you can tell we don't do a lot of prepping. This is just like, I mean, this is about as tongue in cheek as you can get, and we just jump on here and just start talking about what we know. So
Yeah.
we won't do a whole lot of stats and stuff like that. But this is probably a really important one. Keep talking, Mike. I'm gonna look up some stats on chronic pain and
No,
like
absolutely.
disability.
And this is something that we both treat probably every day. I know I see it every single day. And people don't realize how much it affects life. I mean, I was watching a funny video today that wasn't that funny, but I mean, it was funny, ironic, talking about the pain scale and somebody coming in and saying, "Oh, well, what's your pain today? 10 out of 10." It's like, well, 10 out of 10 is like you broke your bone in half and you can't walk and you're screaming. And it's like, but like everybody's 10's different. So how do you actually rate that? And it was like this back and forth on the video of not knowing how to rate it because the pain scales are all subjective. There's not a lot of objectiveness in the standard pain scale. All that to say that it's such a hard topic because everybody experiences pain differently. Everybody
Right.
does.
Yeah.
So
Yeah, it's very, what we call it, subjective, but I mean, we'll dive into why that is. But yeah, absolutely. What I'm seeing here is, low back and neck pain have consistently been the leading cause of disability internationally, not just in the U.S. So it's a huge percentage. Adults reporting poor general health and adults with a disability experience an exceptionally high prevalence of chronic pain, 67 to 52% respectively, and high impact chronic pain, 48.7% to 32%
yeah.
respectively. So that's straight from the CDC.
And
But
that's
yeah,
one reason that's important because so many people suffer with it. I mean, uh, who was it? I was talking to my massage therapist here, and she actually showed me an old commercial from the early 90s talking about that standard daily headache is what it said. Is an advertisement for aspirin.
oh yeah, I
But
remember that. Yeah,
the standard, like everybody has the daily headache. Here's what you do about it is you just
yeah,
take the aspirin. But there's no
yeah.
like talk about what to do about the headache or how to prevent the headache. It's, oh, this is your standard daily headache. It's fine.
Yep. Yeah. It's all about treating and not so much about like what's causing, the headache to begin with.
Exactly. So this is a
Yeah.
really important topic.
Yeah. Yeah. I agree. So let's talk about what pain is. So this is where it gets really tricky because pain, it's like an exercise in reality. Like, what is reality, right?
Yeah.
If a tree falls in the forest and no one hears it, did it really make a noise, right? Well,
Mhm.
kind of same scenario here. Like, if something that could trigger pain in you wouldn't trigger pain in someone else. So it's all about perception, right? And the problem is when people get into, conditions. So if they have some type of inflammatory condition, let's say like an autoimmune condition, where they've got much more chronic inflammation, we know that those people tend to experience pain at a higher level
Mhm.
chronically and much more intense. So they'll report, some innocuous type of stimulation, like grabbing their arm, as being tremendously painful compared
Mhm.
to, other people who would say, okay, that's not that big a deal. It's more of a perceived stimulation and not really pain, and they would report. So let's talk about like why that is. So I'll just kind of give you sort of the standard chronic pain definition as being characterized by abnormal sensitivity, which is due to the generation of pain in response to the activation of the low threshold mechanoreceptive A beta fibers that normally generate innocuous sensations. So I didn't pull
That's a
that one out of
mouthful.
my head. I just looked that one up. Yeah, we would never describe it as that, but it's basically what we just kind of talked about. It's, that sort of hypersensitivity
Yeah.
to some type of sensation. Now, this is usually, there's like three processes that can happen in the spinal cord that are connected with this sort of sensory processing. So, sensory meaning like different forms of stimulation. They could be touch, heat, vibration, sort of temperature and vibration. Um, that trigger this sort of sensory process. So there's kind of three different processes around that in the spinal cord. There's increased excitability. So it's like we're overexciting those neurons. There's decreased inhibition. So we know that there are certain sort of biochemical sort of markers of pain. Some of these are neurotransmitters that elicit that pain response too, and we can inhibit those pain receptors or those pain sort of neurochemicals. Something like substance P is a pain neurotransmitter that tells your brain that there's a pain sensation. And then you got structural reorganization. This is where you actually have like trauma to the area, like to the spinal cord, like from an accident, like a motor vehicle accident or a fall or something like that, where you actually change the mechanical structure of the spine and the cells inside the spine. So those are kind of sort of the three areas or categories of changes, and people can have every sort of variation. They can have one where there's just increased excitability. We see this a lot in like fibromyalgia patients where they've got this sort of centralization that happens in the brain where the brain just senses pain at a much higher level. So they're very sensitive. Or maybe they have this decreased inhibition where they produce a ton of substance P and they can't inhibit that production. This is actually where like cayenne, like topical cayenne, like Tiger Balm. I love using Tiger Balm for this reason because it helps to burn through your substance P at a really high rate. So if we can lower substance P, chronically, then we can affect this decreased inhibition. And then the structural reorganization part, that's a tricky one because you've got this sort of mechanical change in the structure of the root there in the spinal cord. And so this is where it sometimes requires much more high interventional sort of, levels of treatment. So spinal injections, sometimes surgery, things like that.
And acupuncture can treat it particularly well, which we'll talk about later. But I've treated a lot of those kind of cases where there's structural problems, and amazingly, acupuncture does really well for us. Just crazy. But I'm really glad you pointed out, by the way, that the mechanism, because I think the thing I hate the most is when people say it's all in your head when it comes to chronic pain, because it's like there's so much going on. Like everything's processed through your brain. Like your brain is the one perceiving what's going on and then relaying the information. So it's like, technically it's all in everybody's head. If you want to look at it, like literally.
Yeah. I mean, it's a true statement, right? But it's like, it's usually meant to kind of dismiss someone's pain, that it's just all in their head. They're crazy, and not that it's really in their brain and they're just, perceiving pain at a much higher level.
Exactly. And there's so many different, you mentioned the different ways. It's like, there can be something local, but then your brain locks onto it. And we know that people with chronic pain, like you said, tend to experience even more pain. They're like sensitized to it. So whenever they have that chronic pain, they're going to notice, a lot more. And I've noticed that with my patients too, where it's like when they have other things happen and other injuries, a lot of times it'll be, they'll experience more pain than somebody who hasn't had chronic pain for years might experience.
Yeah, true. And there's so many things that can be that trigger, right? That can increase that sensitivity. So, stress is a big one, that people get into this vicious cycle of not sleeping well because, it's painful to sleep. So the pain wakes them up. So then that lack of sleep is a stress on their body that makes them even more sensitive to pain. And it creates this sort of vicious cycle. And those are the people we just kind of have to knock out, like give them medications and knock them out to sleep so they can actually, get some restorative sleep and try to break that cycle, as much as possible.
Yeah. And you mentioned fibromyalgia. We'll have a whole another episode on fibromyalgia, but sleep. Every single patient I've ever treated with fibromyalgia has major sleep problems. Every single one, 100% of the time, no matter what. It's weird.
Yeah, I agree. I'd say, a big percentage of anyone who has chronic pain probably has some type of sleep issue. And it
Mhm.
may not even be perceptible. Like sometimes I'll have them wear a device like an Aura ring or a loop or something that tracks their heart rate variability. And we'll see like what their heart rate is doing while they're sleeping. And we'll see that it's like stress, like it's indicating like there's a stress response while they're sleeping, which means that they can't get into deep REM sleep, which is that restorative sleep. So again, even though they're not perceiving that they have a sleep issue, like they're not actually sleeping well, we do get indicators that they're not sleeping well, and we have to address that obviously if we're going to make any type of progress. Because again, if you're not sleeping well, you're not getting that restorative sleep, we're always kind of behind the eight ball. Like we can
Yeah,
throw the kitchen sink at you, but it's like it's only going to be minimally effective if we can't get you into restorative sleep.
I agree. I agree completely. I work a lot on sleep as well when I see people. So that's kind of the mechanism. So if somebody comes into you and they say, doctor, I have chronic pain. I've had low back pain and some neck pain for years. I'm just looking for, a natural solution for what I should do. Like, where do you start as far as diagnostics?
Yeah, that's tricky because let's say someone comes in with low back pain. We can take an MRI, we can do an X-ray and an MRI of their lower back, and maybe get some sense of what's going on. But the problem is, you can have two people, and there've been studies that have done this, where they look at several people who have pain and who don't have pain. They pull just people off the street with no reported low back pain. They do MRIs of their back, and then they group those MRIs and they say, okay, these two MRIs look identical, like they both have, let's say, a disc herniation at L4, L5, or something. And then they ask those two people, like, symptom wise, like what's going on. One person may report the debilitating pain, and the other person may not report any pain at all. So when we're doing a workup and we're just looking at imaging, we sometimes do a disservice to patients because they can report a high level of pain that's incongruent with what their imaging looks like.
Yep.
And a lot of docs will dismiss that because, oh yeah, I have debilitating low back pain, but your MRI actually looks pretty good. It doesn't look that bad. So we kind of dismiss it and say, well, it's just all in your head. Like you're just making this up, and you're looking for pain meds,
Yeah.
stuff like that. So that's tough because if you're just working up um, using imaging, then I think you can miss a lot. So I always put patients through a pretty strenuous workup in the office. So I'll do like a physical exam on them, see what actually elicits pain and to what level. And that gets kind of tricky too, because even when people come in and you do the whole pain scale with them, if you did the pain scale today and then you did the same exact sort of stimulant test, tomorrow, they may report a different level of pain given the same stimulus.
Hmm.
So again, that can kind of get tricky. But it's data, so I think that's good to just continually do those stimulating tests to see what kind of pain it elicits, and then you can see over time possibly that the amount of pain that provocation sort of elicits goes down over
Yeah.
time.
I like
Um,
that.
yeah,
And
and this
same.
and lifestyle too. Just to kind of jump back in, but
Yeah.
lifestyle is a big issue. Like I always kind of factor things around sort of the core four is what I call it, which is nutrition, movement, sleep, and stress. And
Yep.
so we try to structure our day based on those kind of core four, the sort of foundations of or sort of pillars of health, right? So I want to work on their nutrition, make sure they're getting enough food in, that they're not eating the sort of standard American diet, which is very pro-inflammatory. So
Yeah.
if you've got a ton of inflammation coming in because your diet sucks, then yeah, obviously that's going to increase the sensitivity of pain that you're going to perceive. Um, and then movement, like teaching people how to move properly too. That's a big one. Most of us don't know how to squat properly, and then that can elicit undue pain because we just don't know how to actually move correctly.
Hmm.
Sleep we've already talked about, and stress we've kind of mentioned too. Like stress could just increase that sensitivity to pain.
It sounds like you have a lot of the same focuses I do when people come in. It's like, what are you doing at home? I'm also, you were talking about eliciting the pain response, recreating the pain. All the patients love that, right? You jam your finger into what hurts and like, hey, does that hurt more?
Right.
But I mean, really, you need to
Yeah.
though, because you need to find out, you know, um, what it feels like. I want to talk a little bit about my experience, if it's okay.
Yeah,
Um,
go for it.
so I have a severe low back issue, mostly congenital, that's gotten worse over the years, where I have a severe narrowing at my spine at L4, L5. It's very severe spinal stenosis that's focal. And
Mhm.
so um, I was having 6, 7 out of 10 pain regularly. And when I saw you, you're like jamming your finger in there. And it's like, yeah, I was like jumping off the table screaming, and you're doing that smile that you're doing right now as you see me screaming.
Oh, I wasn't enjoying it, Mike. I promise.
But what you're talking about is so true, because
Mm.
the way I manage it, I was supposed to get a fusion years ago. I was supposed to get surgery a decade ago. I never did. And I manage it mostly natural now, which we'll talk more about later. But movement is a big part of that puzzle for me. I weight
Yeah.
lift 6 days a week.
Mhm.
Period. I mean, if I miss a day, I'll miss a day, but usually 6 days a week. And my pain levels stay down around 1 to 2 out of 10 if I do it properly, just
Mhm.
with weightlifting, eating decent, sleeping. That's it.
Yeah. Yeah.
And this is like, a severe congenital issue where if, when a doctor looks at my MRI, they're like, oh my gosh, it's like an 80-year-old woman. Like, this is
Mhm.
not good.
Mhm.
Um,
Yeah.
so yeah.
No, I'm glad you do that because it's a lot of times people are they're in pain. They don't want to exercise and move because it's painful. But part of that is just one, learning how to move properly, and two, understanding that a little bit of pain right now, as long as you're doing things correctly, can help decrease pain in the long run. For you, by doing the exercises that help to strengthen the muscles in your lower back, help to stabilize your lower back because it's in sort of structurally it's more unstable than it should be, right? So that helps to protect that area the stronger those muscles are, and then it disallows you to get in sort of a compromised position as well if
Mhm.
you've got more strength around that area, core strength, things like that, so you're less likely to get re-injured or make things worse.
Yeah. And no, that's a good point. And also going back to what you said about diagnostics, that's one reason why MRIs can be misleading though. I mean, there's a lot of people who would look at my MRI and say, don't work out. Like, you're going to hurt
Yeah.
yourself.
Hmm.
You're going to injure yourself, which is true with certain exercises. Like, I don't do deadlifts because I haven't found a
Hmm.
proper way to do deadlifts without setting off my back and having, I can't walk for a week.
Yeah.
So I do alternative exercises. So I think encouraging patients, no matter what their test results say, to figure out what works for them is a good way to start.
Yeah. Yeah, I completely agree. It's all like trying to find ways to move the needle that doesn't create too much pain and dysfunction in the short term. But people have to realize if for this is a marathon for sort of long term success, you do have to go through a little short term pain sometimes, as long as, again, you're doing things right. Um,
Yeah. And there's a lot of trial and error. I mean, both of
mhm.
us, when we see people, there's going to be trial and error. You find out what works for your diet, what works for your lifestyle, what kind of exercise works. Some people can't do heavy weightlifting, and they shouldn't, because they'll injure them. And then some
Mhm.
people do a lot better with it. So there's going to be trial and error where not just don't get frustrated when you try something and it's like, oh my gosh, I had worse pain for a few days, I give up. Like, that's not the solution. Is don't like just to
Yeah.
give up moving. The
Yeah.
solution is to find what works.
Yeah, absolutely. The worst thing I think you can do is sit around or lie around and not be active, because then those muscles atrophy and get weaker. You lose even more stability, which means that, let's say if this is a spinal issue, if you lose some of that muscular stability and the strength, you actually put more pressure on the area that's being, that's been disabled, or
Mhm.
you have some structural issues too. So you could actually make it worse by not moving and not doing, what you need to strengthen that area.
Exactly. And something else I said, I want to make sure I don't mislead anyone. There are times for surgery. I'm not saying surgery is bad. When the time comes for me to get surgery, I'll get surgery. And when that time comes. But until then, I'm going to manage it naturally, because especially with fusions, I usually see those patients 7 to 8 years down the road after the fusion, and everything is worse than it was before, because you were talking about this. It's like when you have that disability in the one area, it spreads. And so all of a sudden your L4, L5 is fused. 7 years later, you've put so much stress on L3. Now you have problems there. You have problems above and below.
Yep, absolutely, 100%, man. Because again, you didn't address the sort of main issue there. It's like all right, maybe you have some congenital like stuff like you have with your lower lumbar spine.
Mhm.
Okay, well that's great and all, but if you would have fused that, yeah, and didn't change like your habits and things around like strengthening your lower back, you'd probably have those kind of issues with L3 and segments above that area. So yeah, this is a tricky one to navigate because pain will inhibit people from doing a lot of things that they
Yeah.
should be doing just because it's uncomfortable. We don't like to be in pain all the time. Makes us make poor decisions in a lot of different areas, and it's just hard to pull yourself out of. And it's like the more pain you're in for a longer period of time, the more centralized your brain gets to pain. That pain signal. So
Yeah.
the more intense that pain feels to you. So it becomes a really vicious cycle very quickly, which I
Yeah.
can understand why people go to pain meds, opiates, and why we have such a major opiate issue, yeah, in the country and around the world right now, because
Yeah.
they can get very addicting because nobody likes to be in pain. We don't want to sign up for that long term, especially, and doing some of the things to get you out of that create more pain. So,
Yeah.
I mean, it makes sense that people just don't want to jump on that train and do those things, but it is oftentimes what's going to help them in the long run.
Since you opened that box, I'm going to ask about meds now. So what do you think about different pain medications that are being used? Helpful, not helpful? What's your opinion?
Yeah. So when people, because this is a really common question, like what pain meds are good, which ones are bad, and the study I like to reference is this one where they compared natural anti-inflammatories to NSAIDs, which are those non-steroidal anti-inflammatory drugs. And some of these can be over the counter, like ibuprofen, naproxen. Those are NSAIDs. And what they did was they had these groups do both. And so the natural pain relievers, things like turmeric or curcumin, boswellia, things like that you'll find in sort of all natural, anti-inflammatories. So they had them do both. And what they found was in the short term, like less than 12 weeks, the NSAIDs like ibuprofen and naproxen worked better to reduce pain. But the interesting thing was once you started exceeding that 12-week period, started getting into the 6 month, 9 month, 12-month period, we saw this change in the curve. So with the NSAIDs, it started coming down. So their pain levels were increased. And with the natural anti-inflammatories, you saw this really slow, steady improvement in pain the longer that they took it. So
Hmm.
what I generally tell people is, yeah, NSAIDs are fine to take in the short term, but that's all they are is a
Hmm.
short-term fix. So they're great for flare-ups, and we can use pain meds for the same reason. If you're going to use a Celebrex or something like that because you've got extensive osteoarthritis, you want to use that sparingly and only when you have to for like flare-ups, and then use these natural anti-inflammatories, or things that help reduce pain like PEA. Use those for the long term. So those are
Yeah.
sort of your foundational things, and then you can always throw in the other NSAIDs, as needed as you get flare-ups and stuff like that.
Yeah. I think
So
you're
that's
exactly
yeah,
right.
that's kind of the foundational, conversation I have first, and then we can always go into, more things like injection therapies and stuff like that, acupuncture,
Yeah.
things that can help them as well. But some of those are kind of case dependent.
Yeah. I agree. And I've noticed over the years that the people who are on the most pain medication, and I'll start with opiates actually, because it was a lot more common when I first started practicing to have somebody come in on 240 milligrams of oxy because the doctor didn't know what to do with their pain. For anybody who
Mhm.
doesn't know, that's the equivalent of 48 Percocets. Like if somebody was taking 48 Percocets, that's the equivalent.
That's a lot.
It's a lot, but it's not like they just jumped onto that, because that would kill anyone who just started taking that. You would die. I mean, probably you'd just die. So it's this slow curve where it actually started helping them a lot in the beginning. The first couple months, they probably had the best pain relief they've ever had from their chronic pain. And they're like, this is amazing, amazing. And then your body gets used to it. The receptors stop doing what they do, and you need more. And you don't get as much pain relief with more. And then you need more and you need more. And what I found is those were the patients who were in the most pain, because their receptors were so jacked up at that point that they were not creating any of their own endogenous opioid, like nothing. It was all coming from the medication. So, and NSAIDs aren't quite the same, but it kind of is the body adapts. The body's really, really good at adapting.
Yeah. Oh, yeah. We've seen this even with the NSAIDs. It's like, 800 milligrams of ibuprofen works great now, but you can't keep doing it. Now, 2 months down the road, you're needing double that and triple that. And now you start getting into, potential side effects like, the stomach issues that you can get. Also, too, long-term NSAID use, we know inhibits collagen synthesis. So, which is like the connective tissue in your joints. So if you're taking, 1,200, milligrams of ibuprofen every day for your knee pain, eventually that's actually making your knee pain worse because it's degenerating that area faster because you're not able to repair that collagen, the connective tissue in that area. So it can have sort of a detrimental effect long term if you're taking it. So again, you're right. Like a lot of it's just about receptor sensitivity, right? So we want to use those things sparingly so that we get the most bang for our buck as far as our receptors go. Otherwise, we're doing ourselves a disservice because we're just going to have to load up more and more, which then causes more side effects.
And it also increases
gets to be a slippery slope.
Yeah. Increases risk of stroke and heart attack, we found out in recent years, which is terrifying. And you're right, though. I know somebody who started out taking, a couple ibuprofen here and there for their back pain. Now they take 800 milligrams 4 times a day, which is above what you're supposed to be taking. Just not good.
Yeah, it's not. Again, it's a really slippery slope. You can get into a lot of trouble really quickly without intending to do so.
Yep. One more medication question, because I get it all the time, and I know you probably do too. Nowadays, not every doctor, a lot of doctors prescribe gabapentin for everything. It's like if you have any chronic pain, you're getting gabapentin. What's your opinion?
Yeah, I actually like gabapentin. For a lot of people, it works really well, particularly patients with fibromyalgia. Most of them tend to do pretty well on it. Granted, I think it is overused just because I think as a culture, like medicine is trying to really being intentional about shifting away from opiates. And so there has to be something, right? And there's only so many tools, in the toolbox for conventional medicine. And it's just more medication. So I think gabapentin is the lesser of the evils. Is it overused? Absolutely. But as far as the scale of strength of medications and their sort of side effect spectrum, I think gabapentin's pretty good. And like I said, I do feel like it works pretty well for a lot of people. The only issue is people don't realize like they still have to do those other things. It's like going back to the lifestyle stuff, the core 4. They still need to change their diet. They still need to improve the way that they move and their sleep and their stress and all those things that are going to contribute to your pain. Otherwise, again, like we were just talking about, you're going to have to continue to increase that gabapentin over time and just continue. So that can't be like your only go-to method of reducing pain. So.
I agree. And I agree completely. I've seen some people who knows good benefits from it. I've seen some people who have to stop taking it because of side effects, but I think it is a lesser of evils as far as I'm not a huge fan of it, but it's much better than dying from an opiate overdose. If you were to choose between those, I would say that not dying from an overdose is probably going to be a better choice.
Right.
But you were talking, so I totally skipped over this. See, this you were mentioning like we play it by ear. We do. So from the Chinese medicine perspective, when somebody comes in, pain actually has a couple different things. It's not just going to be kidney this time, Ash.
Oh man, I was going to jump on kidney. Dang it.
Actually, mine would be kidney because it's congenital, and almost anything congenital, anything genetic that has a genetic
Uh,
component
uh,
is kidney in Chinese medicine, almost
so
always.
I am right.
A little bit. You could just guess it. But actually, it's really interesting. In a lot of Chinese medicine with acute pain and some chronic pain, it's called qi and blood stagnation. So basically, what that means is that there's a blockage. And
Mm,
it's like if you kink a hose
mm-hmm.
and water can't get through the hose and it builds up pressure. That's the idea you're looking at, is it builds up that pressure.
Ah, okay.
And if you don't undo the kink, it's going to create more and more pressure, which creates pain. So basically, things are not moving in the system the way they should be.
Well, yeah. I mean, Chinese medicine a lot is based on qi, right? Just kind of
Yeah,
that movement of energy. So if
yeah,
you get a blockage in that qi, then you're going to get some type of repercussion. In this case, it's pain.
yep, yep. And
Am I
so, and
understanding that right?
eventually it starts to block the function. So when I say blood, it's not just like, oh, you got a blood blockage because you might die.
Yeah, it's
I'm
not a
not
blood clot,
talking,
right?
yeah, not a
Yeah,
blood clot, not a blood
yeah,
clot.
yeah.
But
Okay.
really, it's about function. Like it starts with like sub functional, where it's like, yeah, I noticed a little bit, but it's not a big deal. And then it starts to affect function. So that's the way I look at it from a modern perspective. Is it
Yeah.
starts out where it's just some pain, and then eventually it starts to affect your function and how your body functions normally. And
Mm.
at that point, you get that stagnation. Basically, things can't move, which means you can't move, which causes pain. So
Okay. So do you normally treat, like if you're putting needles in, are you treating the local area, or are you treating other areas to sort of help release that
yes,
blockage?
yes.
Both?
No,
Yeah.
both. All,
Okay.
yeah. So
Yeah.
actually, a lot of people will only treat one or the other. So a lot of acupuncturists are like, I'm only going to treat the distal points, so the points on the hands or the feet to help with it
Mhm.
at the ends of the nerves. And then a lot of people are like, no, I'm only going to treat right around the spine. So if you have low back pain, I'm going to treat the nerves at the spine because that's where your pain is. I guess I'm very
Yeah.
American in my acupuncture. I'm just like, why not both? Like,
Yeah. Yeah. Just do it all. Yeah.
do it all at the same time. It's such an American
Yeah.
idea. Just do it all. Just do it all.
Right. Right.
Yeah.
So if you do it all, do you risk like a flare for that person? Like, could you potentially cause more pain, or like what's kind of the idea behind the different perspectives?
Yeah. You do risk a flare if you do too much. And a lot of that depends on constitution. What I mean by that is if I have a big burly guy in his late 20s who's had chronic back pain, who works out all the time, but just has this chronic back pain, I can do a lot more with that guy. I can do bigger needles, I can do more stimulation. He's going to be able to handle a lot more. Whereas if
Mhm.
I have an 82-year-old elderly woman who's had chronic back pain, I'm not going to throw 30 needles in this woman. I'm not going to go super deep because I
Yeah.
will definitely flare her up.
Mhm.
Um, and so I think it's case dependent. And a lot of it is also trial and error because everybody's body's different. So if I do those points along the spine, they're called the Hua Toe points. There was a doctor
Mm. Okay.
1,000 years ago named Hua Toe,
Hmm.
and he came up. What?
So Chinese medicine does the same thing that modern medicine does, right? They're naming stuff after
Yes,
themselves. Yes.
absolutely.
Okay.
He named it
All
after
right.
him. He was
I
the great doctor.
I thought Chinese medicine was better than that.
Yeah, so Huatou came up with these points, and it's really interesting because they're actually along the nerve roots, the dorsal nerve roots on the out off to the side of the spine. And so you actually bury these needles. You can't see me if you're listening, but about a half inch to an inch out, you bury these needles straight down towards the nerve bundles. So,
Wow.
and you go pretty deep in, but really, really good for people with nerve problems that are originating from the spine, functional issues.
Hmm.
Um, but let's say somebody has sciatica. Well, I'll do the points from L4 all the way down to S2, S3 for this
Hmm.
along the nerve. So I'll go every single nerve that could possibly be connecting to that sciatica. I'm going to put needles down towards those nerves. But then I'm also going to do nerves along the legs all the way along that sciatic. So I'm treating at the points where most of it's probably originating.
Hmm.
And I'm treating all along that line and working on the whole sciatic as well, because there could be muscular issues. There usually are. It's like, it's not just
Hmm.
functional, it becomes muscular as well. Your nerves are sensitized. And so I'm treating it all at the same time. And if I do too much, I'll know it. They'll come back in, they'll be like, man, I was sore for a day afterwards. That sucked. Like, yeah, we did too much. I'm backing it off.
Gotcha. Yeah. I mean, yeah, I do the same thing. Like you go into it with sort of this perception of what you want to try to do and accomplish, but you have to adjust. Like every patient's different and how they're
Yep.
going to respond. So you just have to adjust your treatment strategy as you see how they respond to that treatment. So
Yep.
yeah, I think
Yeah,
that's
I would
pretty
never
important.
treat a fibromyalgia patient like that, by the way. I do minimal,
Yeah.
the minimal
Yeah.
that I can possibly do to help them without setting them off is what I do
Yeah.
for fibromyalgia.
Man, I remember when I was in my 20s. I was a personal trainer at the time. And it's like the less you know, the more you think you know, right? It's the
True.
whole sort of Dunning-Kruger effect.
Yeah.
And I thought I just knew it all at that point. And I had this client come in that had fibromyalgia, and she was in her 30s. She looked like she was in pretty decent shape, and I thought, all right, whatever, it's fibromyalgia. I thought at that point I didn't really give it much credence, so I put her through probably a little bit more than a basic routine, and it knocked her out for like 2 weeks. Like she couldn't move.
Okay.
Her husband came up and chewed me out, which does, understandably so, and I deserved it. But that was kind of my first experience with it, going like, okay, these people are different. Like you
Yep.
can't necessarily tell just like looking at them, but they obviously respond significantly different than other people do to the same type of stimulus.
Yeah, I agree completely. And I've learned the same lesson over the years because I learned from doing too much, causing a flare, making a patient
Mhm.
really upset. And so over the years, you learn like, okay, don't do that anymore, like back it off. And they tend to
Yeah.
respond really well, though. Like when you find that regimen that works for them, they
Mhm.
respond great to it. You just have to find what works for them.
Yeah, and that's tricky because it takes time.
Yep.
It's like you have to go low and slow typically with these people, and that can be frustrating too because they want to see they're coming in paying you money. They want to see results as quickly as possible, and you're telling them, "Hey, we need like 8 more weeks or 12 more weeks of doing this before we're going to see a significant improvement." And it's like that's a hard pill to swallow. You know?
It is. That's funny that you mentioned hard pill to swallow after talking meds.
I threw that and see if you're going to catch it.
So yeah, I talked a little bit about what I do as far as acupuncture. There's also some Chinese herbs. My favorite herbal formula in the world, which I still am supposed to send you a bottle and haven't,
Oh, is
is
this the bone water stuff?
so it's called evil bone water, but it
Yes. Yeah.
actually the actual translation is vanquish evil bone water, which
Oh,
makes a
okay.
lot more sense.
Absolutely. I was like, who wants to drink evil bone water?
Yeah.
But vanquishing evil? Now I can be on board with that. That's
So yeah,
that's
this is
awesome.
like 600 years old. They used it for
Wow.
various things, including in the army for injuries.
Okay.
And this particular formula I love a lot. It's one of my buddies who's a Chinese doctor does this, and he actually sourced all the herbs. These are all imperial grade organic herbs that he sources. He makes it himself
Hmm.
in his warehouse, basically with Everclear.
Okay. I thought you were going to say his kitchen or bathroom or something or
He probably
garage.
started there. He started there.
Yeah.
But don't drink it. It
Yeah.
says topical use only. It will not kill you if you drink it. You just don't want to drink it. It tastes
Oh,
horrible.
okay.
But
Yeah.
you mentioned Tiger Balm. It has some of the same ideas. So it has some natural numbing qualities with a lot of the herbs in it. It also
Hmm.
stops bleeding. So if you have a burn or a bleed, it's really good for that, for disinfecting and for stopping the bleeding. And it has natural camphor in it from the herb that will help with that substance P.
Yeah.
So
Yeah.
you're basically
Nice.
treating a lot of different things at once. So basically, anybody that comes in, if they have any pain, I'm just slathering this on and telling them to buy some because it works.
Yeah. Nice. Nice. So one thing I want to throw in there before I forget, because it kind of popped up a few minutes ago, is osteoarthritis. So osteoarthritis is probably one of the more common causes of disability. As we get older, just kind of wear and tear arthritis. And we used to think it was just all structural issues, like this is just a wear and tear of the joint, like your knee joints are just wearing down over time, just because of overuse or whatever. But recent research has showed us like there's an actual like metabolic like issue that goes on with osteoarthritis. Like we know now that people who have like diabetes or some other known underlying metabolic condition, actually their osteoarthritis gets worse quicker. So it
Hmm.
progresses so much more quickly than if you didn't have those conditions. So we're
Interesting.
starting to see this connection. It's still not completely like understood, but we are seeing a sort of metabolic condition like associated with osteoarthritis. So even more reason like you need to work on those core four issues with your nutrition and movement, sleep, stress, and all that even if you do have osteoarthritis, and not just be dependent on the localized treatment.
Yep.
Localized treatments are great. I usually kind of go through the progression of injection therapies, that would be good for osteoarthritis and other, injuries to localized joints, like starting with viscosupplementation, which is basically just injecting hyaluronic acid like a lubrication into the joint so that you get better glide with that joint. And then moving into something like prolozone, which I know it's been around for a long time, but I'm just kind of getting into myself, which looks phenomenal. I've seen patients just have some wonderful benefits from injecting like a sclerosing agent like dextrose and some nutrients like B12 and stuff, but also injecting ozone into the area, which oxygenates that area and helps that degenerative process kind of slow down. And that's part of
Mm-hmm.
the issue there is people get, let's say, a localized injury, it gets inflamed over and over, say like a tennis elbow or something like that. And then, but eventually it becomes less of an inflammatory condition and more of a degenerative condition. So there's a switch there in like the etiology or sort of cause of pain. Once it becomes degenerative, doing a bunch of anti-inflammatories and things like that aren't going to be that helpful. You actually want to go in and create a localized inflammatory response. So this is where dry needling, acupuncture, like prolotherapy, going in and kind of punching holes in the tendon or the muscle to elicit an inflammatory response actually helps helps that area repair better from that degenerative process. So the prolozone kind of works that way too. And then eventually you can get into like PRP, which helps to migrate stem cells to the area, and then eventually like stem cells themselves, which again, we're still kind of learning how to use those appropriately. But anyway, that's kind of the progression I will go with people if they're thinking about doing some type of localized injection therapy.
Yeah, I like that. I'm glad you mentioned that too, because with Eastern medicine, it's actually similar. Like it starts out with you get stagnation where like it's that excess inflammatory response. And then once you get degeneration, that's where it becomes deficiency and like kidney deficiency, all that. So it's kind of the same idea, just different terminology, like we've talked about just about every week.
I know. It still always comes back to that. You guys are saying the same thing, just in a different way.
Yeah, exactly. Exactly. And I think, I mean, what you brought up is really good though, is, those pillars and what people do at home. I focus on the same thing because it's like I can help people. And if you want to see me twice a week for the rest of your life and don't want to do anything else, then you can do that. But my goal is for you to not have to come in twice a week for the rest of your life, and I mean, even if you want to, it's just not healthy to have to keep that regimen up. And if you're not doing stuff at home, that's how it's going to be.
Yeah. Yeah. I tell people all the time, like, my goal is for you to basically put me out of business where you don't need me. Like,
Yep.
we're going to see each other a lot early on, but part of this is like teaching you what needs to be done. And so that you could take responsibility for your own health and do as much of these things as you possibly can yourself,
Yep.
and need less intervention. Yeah.
I like that. This is awesome, man. We're gonna have to talk a lot more about pain because we've touched on a lot of these, different
Yeah.
diseases and different subjects that we're gonna have to have whole episodes on.
Yeah. And this is kind of this is the goal right now is we're addressing a lot of broad issues broadly. And so eventually we're going to come back around full circle and hit these issues again and just dive into much more precise and sort of the nuances of all of these things and talk more in depth about different aspects of these large sort of topics like chronic
Yeah.
pain.
Yeah. And like when we talk about sciatica, we can mention that it's a pain in the butt.
Uh,
Sorry. I had
no,
to.
No, you're not. No, you're not.
Man, I know we're running on time. Is there anything else
Yeah.
you want to talk about with chronic pain or bring up?
No, I think this is a good place to stop.
Yeah.
Let's stop here, and like I said, we'll come back around to these issues and talk more specifically about like treatment strategies. I think is a really good one. Like if we did osteoarthritis and just talked about treatment strategies for OA, that we could do a whole episode easily on that.
I would love to. I think that's definitely going to be something we need to do. And if any of you listeners, if there's any topics you really want to see covered, again, just email us at drunkenmedicine@gmail.com, or just get a hold of us, because we're glad to do whatever you guys and gals think is just going to be helpful.
So Mike, I got to ask, did you dress up for May 4th? May the 4th be with you.
I did not.
Did
I
you?
should have.
You
I
didn't?
forgot what date it was. I didn't even remember the date.
Oh, I'm disappointed, Mike.
I know. I love Star Wars too.
Yeah, I figured you did. Anyway, I had to ask. So.
Did you? You got any pictures?
No, I'm not really big into dressing up for much of anything. So no.
I couldn't tell.
Yeah, I know.
I got the nice hat on today, though.
You do. The hat is groovy. I do like the hat.
Groovy. I love that.
It's groovy. Yep.
Groovy.
All right, man. Anything else before we wrap up here?
No, I think this is great, and I'm looking forward to the next episode. And thank you all for tuning in and listening. It's just great.
All right. We will see you next week.
Have a good one.